Hi, Dr. Volkow. Thank you so much for joining us today to help us kick off National Treatment Week. As you may know, ASAM has a campaign called Why I Treat, where we ask clinicians why they've chosen to treat addiction. And this is intended to encourage medical students, residents, and others to consider becoming addiction treatment providers. So we'd love to start off by hearing why you choose to treat and research addiction.
Well, hello, Dr. Boyle and Maureen, if I can call you. It's a pleasure to be here. And indeed, why did I choose to treat addiction as a physician and then also to do research to understand it better? And the reason is clear, and that is addiction actually negatively impacts the well-being of people. And it is highly stigmatized, and many physicians actually do not consider it even a disease, or if they accept that it's a disease, they actually say, but it's not my job to treat it. And these are things that people are doing to themselves. So there is always that moral judgment that is basically interfering with the proper care of patients with a substance use disorder. And if you look at it from comparing substance use disorder with other medical conditions, you come to realize that they really do not differ in terms of what may be perceived as something that you have inherently biological that makes you more vulnerable versus also the conditions in which you are brought up that may make you more vulnerable to diseases. And we all recognize this very clearly now, for example, with COVID, where we're seeing that people that come from underrepresented groups are much more likely to get infected. And this is not because they are actually biologically more susceptible, but because their economic conditions actually forces them to work sometimes in conditions that are not necessarily safe for the transmission of the disease. And the same thing relates to addiction and adolescents and young people who start to experiment with drugs are actually in environments, social environments that promote that behavior. And fortunately, only a small percentage of them will go into addiction. But those that do go into the addiction have that vulnerability that requires attention. The other aspect that clinicians cannot ignore is how frequent medical comorbidities are in individuals with substance use disorder. So if they do not screen for substance use disorder in their patients, whether they are going there for cardiovascular reasons, for pulmonary reasons, for metabolic diseases, it doesn't matter. The rate and prevalence of substance use disorders across almost all medical conditions is much higher than those of individuals that do not suffer those conditions. And these reflect multiple factors, including the negative effects of drugs in physiology, but also importantly, the lack of medical attention for individuals with substance use disorder, which brings me back to the first point, why I took it. I mean, the notion of stigmatization and discrimination of people that have a substance use disorders lead them to be less likely to seek medical attention when they have another medical condition because they do not want, that they are afraid of being mistreated. So those chronic conditions exacerbate because of this stigma. And it shouldn't be like that. And that's whereupon I basically made my life, professional life, to actually change that cultural rejection of addiction as a disease and to basically provide the evidence that does basically not just justifies it as being recognized as any other medical disease, but importantly, that help us understand it. And also very importantly, that help us develop treatments. So that's a long answer to your short question.
Well, thank you so much for sharing that. I think that it's really interesting to me how these biological, psychological, and social factors all combine to impact someone's vulnerability to these types of diseases, and how those factors, even within the medical system, act to contribute to the continuation of them. It actually, it brings us to one of the questions that I was going to ask around implementation science. So, as you know, in the highest quality research studies we have, we can achieve much better outcomes than we see in the real world. And I know that this is something that NIH and NIDA are putting a good deal of resources into to try and understand how we can better translate what we know, from the research into the real world and have better outcomes for the community. I was wondering if you could tell us a little bit about what we're learning from those studies and what clinicians can be doing to improve translation.
Well, and that is, I think, an extremely important question. How do you properly implement an intervention such that you are following the guidelines? And this is very, very important if we want to actually improve the quality of care on the treatment of substance use disorders. Unfortunately, evidence for assessing quality of care on the treatment of substance use disorder has not been a priority, and this is something that we're trying to change. And so one of the first strategies is to develop metrics that enable us to assess the quality of care provided in treatment programs and to quantify it in such a way that it can be used to guide which interventions are likely to result in the best outcomes. So we need to start by developing metrics that evaluate the quality. So if you have a model that you want to implement, even if sometimes if it's not implemented perfectly, exactly, it still can be very valuable. And it may be that a model that was developed for one community may not be so easily translatable into another community. So you need to understand those parameters. And if you are not monitoring them, then you will never know where is it that there may have been gaps and opportunities for strengthening it. So this is a key component of what we're doing with implementation science. And we are relying actually on the communities that provide the treatment to give us those metrics and to actually take advantage of their innovation on how they bring a model and implement them into the specific setup and evaluate it. So yes, the implementation, the fidelity of implementation is crucial, but it's so important sometimes to also recognize that in certain instances, adapting to the needs of the culture where you are going to bring it is also extremely relevant. And we see, for example, this being very important when we bring treatment programs to American Indians or to Alaska Native communities that have certain cultural elements that are very relevant to them, or when we bring, for example, treatments that have been beneficial to adults into adolescents, and then we find that they actually do not work in this age group. So that is a key component of the aspect of implementation science. And finally, I think that too, the notion of having the treatment providers, the stakeholder, identify what their needs are and what are their strengths to maximize their capacity, not just to implement, but extremely importantly, to sustain that implementation. Because what we see repeatedly is that a model shows evidence of benefit, and then it's implemented and for a short period of time, and then it's neglected. And so the question is, what is it necessary to sustain that model so that it becomes accessible? And that's another aspect of research.
Yeah, well, those are incredibly good points. And I think another way of another aspect of adaptation that we're learning about right now is adapting to the times, right? We're in incredibly challenging times for the field. We know that there's been a devastating 30% increase in overdose deaths in 2020. Probably a degree related to the pandemic. But we're also learning from the pandemic about ways of increasing access to care that weren't necessarily existed before, but just there were real challenges with implementation, and the pandemic has kind of forced those into the forefront. Can you tell us what we're learning about learning from the rapid adoption of telehealth and how we see the future One thing I'll say to frame this is, I've spoken to a number of ASAM members over the last couple of years around, or over the last year, about their implementations and their experiences with telehealth during the pandemic. And we've heard a lot of positive things in terms of increasing access to care and getting better insight into patients' lives through kind of seeing video feeds. But some also noted challenges. So specifically that they're not really seeing the warning signs of relapse the way that they would in person, and sometimes that they're not getting to the same depth of conversation with patients, through telehealth. So I'd be curious to know what we're learning from the research that's been going on over the last year, and what NIDA's research priorities are going forward.
Yeah, no, it's an important question. And, NIDA had been doing work on telehealth to try to actually learn how to optimally study it in patients with a substance use disorder. And the data, for example, speaking about models, there were models that had shown that an hybrid model between the use of telehealth and face-to-face interactions with the therapeutic provider actually resulted in equivalent or sometimes even better outcomes than models that just relied on the physical presence. Now, despite the data that existed that there was definitively benefit on the use of telehealth, it was not being implemented, which related to a lot of roadblocks that existed to get approval for reimbursement on telehealth. And of course, that rapidly and dramatically changed with COVID. And as a result of that, it became much more available for clinicians to be able to provide telehealth interventions and for patients to have access to those telehealth interventions. I would say that it has been transformative. It has been transformative because, to start with, for example, as you know, it is now possible for clinicians to prescribe buprenorphine through telehealth, which was not possible in the past, and that expand their range and their influence, because they even now, also another very important change has been that you can prescribe buprenorphine without having to get the waiver as a clinician. So this was a deterrent for some clinicians that did not have sufficient access to many patients to say, well, it's valuable for me to get the waiver. But now that is not necessary, so it expands it. The same thing in rural communities where there may not be a clinician that can provide a buprenorphine treatment. So that is an aspect that has been transformative. Another element that has been transformative is we know that it is substance use disorders, and the more severe, the more likely this happens, are frequently comorbid with psychiatric diseases. And we also know that it is crucial as part of the treatment intervention that the treatment of these comorbid psychiatric conditions be actually taken into consideration in parallel to the treatment that's going to be actually developed towards the patient's substance use disorder. So you cannot separate them. You have to actually integrate that care, or certainly ensure that there's proper communication if, for whatever reason, that care is not integrated, which is, of course, the ideal setup. You need to approach it. And through telehealth, that has become possible. And in places where, for example, someone suffering from a bipolar disorder, where there are not psychiatrists, think about a rural area, and were sort of highly comorbid with substance use disorders, including opioid use disorder, those individuals were very, very neglected, and they didn't have access to treatment. So that has been very useful, as has been useful also for individuals suffering from substance use disorder, comorbid or without comorbidity with psychiatric illnesses in justice settings, where actually very few justice settings have access to psychiatric expertise. And basically now, through COVID, they have opened their doors for telehealth, and that has provided another way for clinicians to be able to take care of very vulnerable patients. And I'm speaking in terms of comorbidity with psychiatric diseases, but I already mentioned that comorbidity with medical conditions is extremely high. And that can be, for example, hypertension, diabetes, COPD, you name it. And it is something that we don't pay attention to, and we should. So to the extent that we now have telehealth, that also should open up the feasibility of taking care of the medical needs of patients with a substance use disorder. There are challenges, and definitively there are situations like anything in medicine where you, for example, you can use telehealth to monitor certain medical conditions, but there are certain instances in terms of where the physical evaluation becomes indispensable. And that is, again, you can discuss it in terms of looking at it in severity, that there are certain circumstances where the telehealth intervention is a perfectly good way to provide care, but there are others where it may not be. And having the flexibility of, again, hybrid models where you can, depending on the circumstances, be able to accommodate for a physical need is quite important. Obviously, in many instances, the cost associated with an in-person visit may be higher than those through telehealth. There's also another issue that needs to be considered, and what that assumes that everybody has access to bandwidth or technologies that will allow them to have access to telehealth. And what we've learned from research is that that's not the case. We should have known that because there are tremendous income inequalities, and people with substance use disorder and also with mental illness are much more likely to basically not have necessarily access to these technologies. And as a result of that, again, what the creativity of researchers has been is, can we provide, there are models, for example, of buses that go to areas where people, because of very low incomes and deprivation, don't have access to web-based technology, so that they can access telehealth in these mobile I would sort of say medical offices, mobile offices with that are actually based on models that have been applied for HIV and that we have also applied for syringe exchange programs. So using, tools are there to be used, and they are there to be adapted to what's necessary. So this is what the research is showing. Clearly, many benefits, of course, certainly some challenges, and identifying situations where the physical, the inability to get access to a face-to-face interaction has led, in some cases, to patients being less able, as you were pointing out, to have the support to prevent a relapse. But overall, because you have to judge positives and negatives, overall has been extremely beneficial, while recognizing that it's not a black and white, and that, again, the issue of flexibility and capacity to accommodate is what ultimately is an ideal intervention.
Yeah, most of the clinicians that I've spoken to have talked about moving to a hybrid type of care, right, where you're integrating telehealth, when it's convenient for the patient, when they wouldn't be able to access care in the absence of it, to kind of allow them to attend more treatment sessions, but also, I think they're trying to figure out the lines where, when do we know that a patient really does need to be seen, in person by a clinician? And I think there's a lot of, lessons being learned right now that we're going to be capturing for the future, hopefully. As you may know, ASAM has what we call the ASAM criteria that really brings a biopsychosocial model to addiction treatment. Talks about the integration of physical health care, mental health care, and substance use care, and defines the standards for assessing patients as they come through the system, and making sure that all of those aspects are taken into account when determining a treatment plan. And I know that our editors for the 4th edition are actively working on how do we set standards for the integration of telehealth and other technologies into kind of that next generation of care.
Yeah, no, and I think that is a unique opportunity, because in the process, we will be gathering data and learning from those experiences so that we can optimize. And for example, one of the things that we are doing also is promoting research in the space of translation and innovation to create applications that can facilitate engagement of individuals that are being monitored through telehealth and ensure that they actually can be evaluated properly in case there is an impending relapse. And also to provide the support systems that are necessary for people suffering from addiction to retaining treatment. And we are all, right now, this is very, very relevant because we have been faced with a COVID pandemic as of now. I mean, certainly it has negatively affected the income of some people. Some people have lost their house. There has been an increase in homelessness. There has been an increase in food insecurity. And all of those social and economic factors are actually acting as detriments in an ability of a person to stay in treatment. So being able, as we are battling through the COVID pandemic, or as we emerge, the recognition that more and more these social and economic factors are actually directly impacting our ability to take care of patients. And I would say it's not just individuals with substance use disorder, it's many types of patients, but yes, individuals with substance use disorder and mental illness are at increased risk of homelessness and also of having food deprivation conditions. And within this group, we also have learned that women are more vulnerable because women are the ones that take care of children, and those therefore are much more likely to be evicted and hold jobs. So this extremely stressful life experience that we're living with the pandemic is actually challenging the systems and making us aware that factors that in the past we didn't consider were part of healthcare interventions are now necessary to address in order to achieve the outcomes we want to achieve and to ensure that patients stay in treatment.
Yeah, speaking of the pandemic and hopefully getting to the other side of it, a lot of our members are obviously, reporting getting vaccinated. I think the vast majority of ASAM members are vaccinated at this point, but many have noted resistance among their staff and among their patients. What role do you see addiction treatment providers playing in supporting and encouraging vaccination?
Well, overall, the data has shown that clinicians and healthcare providers are among the most trusted as it relates to conveying the importance of vaccination. So I think that this is a unique opportunity in the workspace to actually openly speak about the importance of vaccination and why it not only protects you, but it also protects your family, friends, and the people that come to rely on you for their treatment or their well-being. So there is a sense also not just of responsibility from one's own health, but our responsibility as social creatures. And that is healthcare providers are in a unique position to do that. They are trusted much more than government officials. And particularly, I would sort of say between communities that have been stigmatized for years, which is actually the case of the people in substance use disorder. The whole notion of criminalization that we have in our country is not very conducive to necessarily trust government organizations, and that's where again relying in healthcare provider is crucial.
Yeah, you've spoken a little bit about issues within the criminal justice system, and as you may know, ASAM is working with the National Commission on Correctional Health Care to develop withdrawal management guidelines for jails. As you may know, there are thousands of people who die every year in jails because of a lack of basic medical care in response to substance withdrawal. And there's obviously a lot of complex reasons that contribute to that. But I know that you've been doing, NIDA has been doing research within the justice system, and particularly kind of, I think, under the broader Healing Communities initiative. Can you tell us what we're learning about improving treatment within criminal justice settings?
Well, yeah, and one of the things, I mean, when you look at the COVID pandemic, of course, it's a devastating pandemic, and it has cost us so many lives and suffering. But it also, because of its urgency, has facilitated the adoption of practices that were very much rejected. And in the case of the justice settings, as you know, there has been overall a rejection of treatment of substance use disorders, of the use of medication. And there is a strong, strong component that relates to the stigma and the notion that people, that it is still believed by many that you're just substituting one drug for the other, and here you have a criminal person and you're going to be giving them a drug. That is slowly changing. And I would say that with the COVID pandemic, and actually before the COVID pandemic already, you started to see the willingness of jails and prison systems to expand access to treatment of medications or behavioral interventions for people with substance use disorder, which was hindered by the lack of providers. But with telehealth, that actually has made it easier. And through the J-Coin, which is the initiative that is funded through the HEAL funds that were given to address the opioid crisis, we're prioritizing interventions that can actually improve the outcomes of individuals suffering from an opioid use disorder. And there's a paper that just came out that actually caught my eye. It came up in JAMA network that was funded through NIDA, that actually compares the efficacy of buprenorphine, Suboxone, versus compare with the extended release buprenorphine that actually requires only once a month dosing of buprenorphine. And they initiated a treatment at least 1 month before the person in jail was released into the community, and they follow them. It's a small study, and I don't think it was something like 60 participants or 64. And they didn't, because the study was small inside, they didn't do statistics. But I sort of, when I say, and I presented it to council, I said, this is the first study I've seen that you clearly do not see statistics to see what a significant effect it is. It's a very large effect size favoring the extended release buprenorphine, indicating that much greater retention in treatment, much less likelihood of taking drugs and negative urine, much less greater retention over a period of time, and importantly, decreased reincarceration. And you don't need statistics to see that difference. I mean, obviously, like anything else that we do in science, you actually have to replicate findings, particularly when it's a small sample. Even if it's a large sample, you need to replicate. But what it does highlight is that we have right now tools such as this new formulation that can make it much easier to implement treatment and to help patients avoid relapsing and to protect them in the process, of course, of overdosing, and to protect them for reincarceration. So this, again, highlighting an opportunity that we have to implement and to evaluate the extent to which indeed extended release forms of the medications that we currently have, which we only have right now for naltrexone, the opioid antagonist, and for buprenorphine. But we're working with one pharmaceutical industry and other researchers to develop also a long-lasting methadone that will also facilitate its implementation and retention of patients. So we are learning in a way, the experiences that that different jails and drug courts are having to face with COVID, when many individuals in justice settings have been released into the community, what works better to ensure that they will be successful. And what is clear is, number one, practices that remove access to insurance, the removal of Medicaid, for example, when you end up in jail or in prison, that has very negative consequences. So many of the states are implementing models that now keep the insurance of the individual so that when they get released, they have access to healthcare. And that's actually associated with much better outcomes. And two, again, going to bring forward the concept of recognizing that now more than ever, it's always been there, but perhaps now it's more acute. We need to address the economic challenges that people that are in justice settings that have a substance use disorder are going to face when they go back into the community, such that they do not relapse because of not having a place to sleep or work to eat. Those are factors that now need to be considered. And we need to figure out our resources to fund to find the funding for them.
Yeah, there's been a lot of exciting movement in that area that I think has the promise of making some substantial differences. But that study that you mentioned is incredibly exciting. I'm sure all of our members will be excited to hear that. I think everyone's been waiting for the head-to-head comparisons of the extended release buprenorphine from the daily tablets, and look forward to seeing more in that area, and particularly on the extended release methadone. I think access to methadone treatment is such an issue, and an extended release formulation would be game changing.
They would, and as you were speaking, there is another area too that requires special attention, and that is women that have a substance use disorder, an opioid use disorder, and become pregnant, and that they actually how to treat them, and where the science also shows that treatment with buprenorphine significantly improves their outcome. Even though there's currently no research on the extended release formulation, the data is already there to show that treatment of buprenorphine actually not just improves the outcomes on the mother herself, but importantly improves the outcomes of the neonates. So their need for staying in the hospital or for morphine in order to address, or methadone in order to address neonatal abstinence syndrome is much lower when they are treated with buprenorphine. We are currently, as part of the clinical trial network, doing a study of mothers who are pregnant that is comparing the extended release formulation from the regular medications. It is a study that is focusing specifically on buprenorphine, and so that we can build the knowledge and see how it's tolerated and what are the outcomes on the neonate. Does it result in better outcomes on the long term?
Yeah, we will be very excited to see that, because I think the steady state medication, theoretically, would be better for both mom and neonate, and so we'll be tracking that closely, because I think that will be of great interest to the clinical community.
Yeah, no, but it's also, one of the things that I think a lot about it is we have evidence-based intervention. We want to evaluate it. We speak about implementation, but you also know very well that one of the main challenges is that people do not seek treatment. And so we have to be very proactive in screening for the presence of a substance use disorder. And I think that this is probably even more exacerbated for women that are pregnant that have a substance use disorder, because of policies by some of the states that penalize a woman if she's taking drugs. It's considered a criminal behavior. And so if they are afraid that if they seek for treatment, they may end up in jail, or they may end up their child in custody. So I think that recognizing that there are still some very punitive practices that are interfering with proper treatment is something that we have to keep in our brains, sort of to bring knowledge that hopefully can change those prejudices and really atavistic practices that just they harm the woman that is pregnant, they harm the newborn that because it's not receiving treatment, and the community itself. So it's a loss-loss situation, and yet it permeates. Again, it's a problem in many of the states in the United States.
Yeah, ASAM over the years has worked with the American College of Obstetricians and Gynecologists to put out policy statements directly talking about this, and encouraging states to avoid this type of punitive response to a medical disease. But there's obviously a lot of work that needs to be done on that still. And you've been writing a lot recently about stigma and its impact on patients' willingness to access care and the quality of the care that they receive. What is the research showing, and what would you suggest that the average clinician can do to help address stigma?
Well, I think that the first notion about it is to be very objective and recognize that, stigma can exist even if we are not consciously aware of it. And that's where the whole concept of unconscious bias, and that it is actually permeates at very different levels of care. And so you have the stigma for an individual with a substance use disorder, but you also have racial stigma, and both of them collide in ways that actually has an even worse effect on individuals that come from underrepresented groups that have a substance use disorder. And what made me think about it is that, for example, if you are a woman, you're pregnant, and you are in one of the states that penalizes you, you're much more likely to end up in jail if you are Black or Hispanic than if you are white. And also, if it so happens that you are a Black person and you have an opioid use disorder, it will take in average 4 or 5 years longer to be given medications that can help your life. So there are these confounding and overall stigma and prejudice against addiction overall that is actually further exacerbated in groups that are underrepresented groups, and makes it even so much more challenging. So we have, it is as clear as if we do not address and get rid of stigma, we're not going to be able to overcome the opioid crisis, or I would call it the addiction crisis that led to close to 95,000 people dying in 2020. We're not, because the most powerful tools that we have for people to prevent overdoses are not implemented because of stigma. The resources that are necessary to sustain actually those people in treatment and recovery are not being provided because of stigma. And importantly, crucially, I would say, the prevention infrastructure necessary to actually protect people from experimenting with drugs, and if they are taking drugs, to escalate into more severe states of their addiction, is also not there. There are no resources. There's evidence that has been shown that many of these practices are effective, but there's no resources to implement them. And so the question in terms of all of this is, and why? Because there is a stigma in the society. And that's why I say very clearly, if we do not address stigma overall with its multiple ways it presents to us, from the going into an emergency room and the nurse mistreating you because you are just an addict and you did this to yourself, to an insurance system that is not willing to cover the cost associated with treatment of addiction because it's treated as a second citizen disease, whereas something like, of course, cancer, they would not question it. So these different levels of the stigma on how we look at addiction and we treat addiction as a society needs to change. And that's why we've been so vocal and making it clear of how it's negatively impact trajectories and how it's negatively impact the life of children as they grow into young adulthood. There's a recent paper actually that made a big impression on me. It's a group taking advantage of our study on the ABCD, which follows prospectively close to 12,000 children with brain imaging, cognitive assessments, behavioral assessments, and deep phenotyping and social and economic factors that are surrounding their lives. And in this study, the investigators, what they basically evaluated was the consequences of discrimination as perceived. And these are children, 9, 10, 11, 12, as perceived of discrimination. And they showed that was significantly associated with a higher risk of suicidality. So it impacted me very much, not because the notion, not expecting that if you are discriminated, we're removing a very powerful reinforcer of social acceptance, making you withdraw, and that makes you more vulnerable. But on top of that, what also impressed me was that children were being already subjected so early on about this discriminatory sensation, and the discrimination is felt very much on the basis of race and ethnicity. It is also based on the basis of whether you have obesity or not, and it's a discrimination, no matter the reason for, is very negative. And so it was, I think that data like this should make us wonder and sort of says, as a society, we have allowed these practices to continue undeterred, even in the 21st century. And there's another paper that was published by investigators using the ABCD that show that children that are Black are much more likely, and Hispanic, much more likely to be suspended from school than white children, even after controlling for all of the variables that increase the likelihood of being suspended, like externalizing disorder or being a male or being all of the factors. Regardless of that, if you are a Black kid, you're much more likely to be suspended. And we also know already from many years of studies that suspension, early suspension from school, initiates a trajectory of much negative outcomes. So, and perpetuates externalizing behavioral disorders that, again, increase the likelihood of taking drugs and increase the likelihood of ending up and not being able to finish school or end up in the justice setting. This is observed even at 9, 10, 11-year-olds in the 21st century. And again, that's why I say, as a society, we need to grapple with how do we get rid of stigma altogether. Stigma for substance use disorders, stigma for underrepresented groups, stigma for religious affiliations. I mean, stigma is a very negative aspect of our social systems.
Yeah, no, and I know that NIDA has other research showing that, for Black adults, the chances of getting underdosed with the medications that we do have, even if you do have access to, to buprenorphine or methadone, that your chances of getting a dose that's too low to be effective, and then, kind of that feed forward cycle of, people saying, okay, well, the medication clearly doesn't work, and if you're not using it properly, then it doesn't work. But I think it's, I really appreciate, and ASAM really appreciates all of the work that you're doing to draw attention to those issues, and anything that ASAM can do to support those efforts and to help get the word out to clinicians. I think my understanding is that NIDA's research is kind of moving more towards the okay, we've documented these issues that are here. We understand the depths of the inequality that exist. Now, what do we do about it? And we'll all be very interested to to see the results of that research, and anything that ASAM can do to help disseminate, we will be very interested and excited to help with.
Yeah, no, and I basically, I mean, it's a great partnership, and we're already very excited for having joined with ASAM and support your Twitter event, which is focused specifically on ending addiction stigma. And for the right reasons. You say the stigma leads people not wanting to go get care because no one likes to be discriminated. It removes, as I said before, one of the most powerful reinforcers that provides resilience that we all have, which is that of meaningful social interactions. It's just extraordinary. We give it for granted. But now that with the COVID that we have been in social isolation, I think many of us have come to realize how powerful, we've known it, but actually how difficult it is to not be close to others, how pleasurable it is to be when you have a chance to meet someone else, and how much we rely on other people when actually we're faced with challenging circumstances. That in substance use disorder has been recognized as crucial for treatment, and one of the reasons why many of the 12 group programs work, because you provide a social system that cares for the person, that the person can trust. And that is removed by stigma and discrimination. You actually remove the ability to take advantage of that very powerful social connection in terms of giving us a purpose of being from an individual. So it starts there. And then it goes into the stigma to the other extreme of society that basically has stigma against addiction as a disease and has stigma against the medications that we use to treat it, that also impedes progress. And not to say the stigma of criminalizing individuals with a substance use disorder. So that's why because it is an aspect that we realize, and now as we're going into our new strategic plan, you help us do the prior one. Stigma is a critical backbone of all of the operations, because we can develop all of the science that we want. If it continues to be stigmatized, it won't have any impact in the individuals or in society. So we need to address it.
And we will work with you to do the best we can to do that. Thank you so much, Nora, for helping us with this today and giving us your thoughts.